Hello friends, welcome to my YouTube channel. Today I am discussing MCQs from Katherine Anderson 550 mrcog 1 book. It is recommended for exam. But as this is old published book, questions on true and false pattern are present, but still it is good book for preparation and revision. Today I am discussing first 3 questions from anatomy module. Further questions will be discussed in upcoming videos. So if you like video, please subscribe my channel and click the bell icon so that you won't miss new video. Anatomy is very important module. 25 to 30 questions comes from anatomy in paper. So let's start. Question number 1 is the following form part of the superior anatomical boundaries pelvic inlet of the true pelvis. And the options are linea alba, sacroiliac joint, ischial fossa, iliac crust, iliopectineal line. Explanation is the female pelvis can be divided anatomically into two broad areas, the fall pelvis and the true pelvis. The fall pelvis lies above the pelvic brim and has no obstetric importance. The true pelvis lies below the pelvic brim and is related to childbirth. The true pelvis comprises an inlet, outlet and cavity. The pelvic inlet brim has the following boundaries: sacral promontory, sacroiliac joint, ala of sacrum, iliopectineal line, upper border of superior pubic rami and upper border of pubic symphysis. So after this we go back to the question. So the first option linea alba is false, sacroiliac joint true, ischial fossa false, iliac crust false, iliopectineal line true. Second question, the diameters of the pelvis. The anatomical anterior-posterior diameter true conjugate is approximately 11 cm. The obstetric conjugate is larger than the true conjugate. The anatomical transverse diameter forms the largest pelvic diameter, approximately 13 cm. The obstetric transverse diameter bisects the true conjugate. The external conjugate has no true obstetric importance. Now the plane of pelvic inlet. This is bound anteriorly by the upper border of the pubis, laterally by the iliopectineal line and posteriorly by the sacral promontory. The average transverse diameter is 13.5 cm and the average anterior-posterior diameter is 11 cm. Obstetric conjugate diameter transversely oblong. It is not possible to measure these diameters clinically, and the only diameter at the pelvic inlet amenable to clinical assessment is the distance from the inferior margin of the pubic symphysis to the midpoint of the sacral promontory, the diagonal conjugate, which is 1.5 cm greater than the obstetric conjugate diameter. So after reading the explanation, the anatomical anterior posterior diameter true conjugate is approximately 11 cm. It's true. The obstetric conjugate is larger than the true conjugate. It's false because obstetric conjugate is 0.5 cm smaller than the true conjugate. True conjugate is measured from the upper border of the symphysis pubis to the midpoint of the sacral promontory, while the obstetric conjugate is measured from the posterior surface of the pubic symphysis to the midpoint of the sacral promontory. So it's false. The anatomical transverse diameters form the largest pelvic diameter, approximately 13 centimeter. This is basically true, although in the explanation a transverse diameter was given 13.5 centimeter, but in some books it is given as 13 centimeter, so it's true. The obstetric transverse diameter bisects the true conjugate, it's true. The external conjugate has no true obstetric importance, it's true. Now the third question is pudendal nerve. It options are arises from the posterior rami of S2, S3, S4, splice the levator ani, leaves the pelvis through the greater sciatic foramen, splice the clitoris, crosses over the ischial tuberosity lateral to the internal pudendal artery. The pudendal nerve is a major somatic nerve of the sacral plexus. Overview: its nerve root is S2 to S4. Sensory innervates the external genitalia of both sexes and the skin around the anus, anal canal, and perineum. Motor splice: it innervates various pelvis muscles, the external urethral sphincter and the external anal sphincter. Now this green color shows pudendal nerve, and it arises from the S2, S3 and S4 of the sacral plexus. Anatomical course: the pudendal nerve is formed from the sacral plexus, a network of nerve fibers located on the posterior pelvic wall. It arises from the ventral rami, anterior divisions of the spinal nerves S2, S3, S4. So it is to be remembered that pudendal nerve arises from the anterior division of the spinal nerves S2, S3 and S4. After its formation, the pudendal nerve descends and passes between the piriformis and the ischiococcygeal muscle. It leaves the pelvis through the lower part of the greater sciatic foramen. It then crosses the sacrospinous ligament close to its insertion to the ischial spine, and then re-enters the pelvis through the lesser sciatic foramen. After re-entering the pelvis, it accompanies the internal pudendal artery and vein, crossing anterior-superiorly through the pudendal canal, also known as Aclox canal, and structure formed by the fascia of the obturator internus muscle. Inside the pudendal canal, the nerve divides in two branches, first giving off the inferior rectal nerve, then the perineal nerve, before continuing as the dorsal nerve of the penis or clitoris. Note there is variation with the anatomical course between individuals. However, its close association to the ischial spine is generally consistent. Now this is a very good diagram. You can see pudendal nerve is arising from S2, S3 and S4, and after crossing piriformis and iliococcygeus muscle, it enters into the greater sciatic foramen. Now after leaving the greater sciatic foramen, you can see at the insertion of sacrospinous ligament, it re-enters through the lesser sciatic foramen and then enter into the pudendal canal, showing with light green color. In the pudendal canal, pudendal nerve is giving inferior rectal nerve, perineal nerve, and after that emerging out, it gives dorsal nerve of the penis. It's a very good diagram. As anatomy, you have to memorize nerves, muscles, its attachments, and also their courses. So it will be very difficult um, if you if you just read. You can't memorize things. But when you read anatomy with atlas or diagrams, it will help you to memorize the things. So it is a very good diagram if it shows the course of the pudendal nerve, and it will help you to memorize its course. Now the motor function, the perineal nerve innervates muscles of the perineum and the pelvic floor. Bulbospongiosis, ischiocavernosus, levator ani muscles including the iliococcygeus, pubococcygeus and puborectalis. The levator ani muscles also receive innervation directly from the anterior ramus of the S4 nerve root. The nerve also innervates the external urethral sphincter, a branch of the pudendal nerve. The inferior rectal nerve provides motor supply to the external anal sphincter. Therefore, the pudendal nerve provides the voluntary somatic control of fecal and urinary continence. Sensory function, the pudendal nerve supplies sensation to the external genitalia of both sexes and skin around the anus, anal canal and perineum through its branches. Inferior rectal nerve innervates the perianal skin and lower third of the anal canal. Perineal nerve innervates the skin of the perineum, labia minora and majora or posterior scrotum. Dorsal nerve of the penis or clitoris innervates the skin of the penis or clitoris, thus responsible for the afferent component of penile and clitoral erection. This added information, basically pudendal nerve block. A pudendal nerve block is a form of analgesia occasionally given before vaginal childbirth, episiotomy and other minor vaginal procedures. To administer a pudendal nerve block, the patient is placed in lithotomy position and the ischial spine is palpated transvaginally. Local anesthetic is then injected into the tissues around the ischial spine. The procedure is then completed on the opposite side. As the pudendal nerve is accompanied by the internal pudendal artery, it is essential to aspirate before injecting local anesthetic. This ensures that local anesthetic is not administered into the systemic circulation. This is the explanation given in the book. The pudendal nerve originates from the interior ventral rami of S2, S3, S4. After passing between piriformis and coccygeus, it leaves the pelvis through the greater sciatic foramen. It then crosses the ischial spine with the internal pudendal artery and re-enters the pelvis through the lesser sciatic foramen. The pudendal nerve passes medially to the internal pudendal artery. Now, after reading the explanation, the pudendal nerve arises from the posterior rami of S2, S3, S4. It's false because pudendal nerve arises from the anterior rami of S2, S3 and S4. Supplies the levator ani, it's true. Leaves the pelvis through the greater sciatic foramen, it's true. And supply the clitoris, it's true. Crosses over the ischial tuberosity lateral to the internal pudendal artery, it's false. Pudendal artery, it is present medial to the internal pudendal artery. Thanks friends for watching the video. I will discuss further MCQs in my upcoming videos.